I want to crave your indulgence that you will please rearrange your thoughts and presentations and make it to be contained within 3 minutes. Thank you. Who wants to take the first shot? I don't want to go in any particular order.
Good afternoon and welcome to the WHO session. This session we are looking at the WHO guidelines, various guidelines on family planning and how this has been applied in country. As we all know, before I start, I'm making this presentation on behalf of the Human Reproduction Team in WHO HQ, led by Dr. James Chiari. We all know that WHO has a broad range of quality evidence-based guidelines, including on contraception, human rights, and on quality of family planning services. But the cornerstones still remains the medical eligibility criteria for contraceptive use, the MEC. That is the book, the recommendation. The current one was released in June 2015. We also have the selected practices recommendations for contraceptive use. This is still under review. The 2016 edition will be released soon. We have the global handbook for providers. We have the decision-making tools and the MEC wheel, which is the most popular used by healthcare providers in making decisions. The team is also focused on continually working on generating best evidences through research and to also determine the impact of these documents that are being produced by WHO. Are they really useful at country level? Are countries using them? So this is the main essence of this session. We go through the main recommendations from the recent MEC, the 2015 MEC, specifically with focus on the postpartum family planning, emergency contraception, and adolescents. So because of time, I won't be able to go through all the slides, but to add that the process of evidence generation in WHO follows the guideline development protocol that we all know. We look at the problems, gather all the evidences, and panel of experts sits to sift through the evidences, and they come up with recommendations which are released globally for translation into policy at country level. So this is the brief introduction about the tools that WHO has been producing and how they have been disseminated. The presentations following my own will deal on specifically on the medical eligibility criteria recommendations, the one of June 2015, how we have been able to use that in Nigeria, and we also look at the innovative ways of disseminating WHO guidelines. Thank you very much.
So first of all, we want to talk about the postpartum period and the family planning methods and contraception recommended during this period. We all know that the postpartum period is a very critical period for women. If it is properly utilized, we are likely to avoid a lot of unintended or unwanted pregnancies. But unfortunately, there is a very high unmet need for family planning during this period. There are many women who will not want to get pregnant, but they become pregnant during this period because the right treatment that ought to be given to them during this period is probably missed out. And it is felt that if this period is well taken care of, many unintended pregnancy can be avoided. And when we talk about postpartum period here, there's the general tendency to talk about the first 6 weeks after birth. But in the context of family planning, as recommended by WHO recently, we are talking about the first 12 months after a woman has given birth. It is not clear that if the right thing is done, it is possible for a woman to be put on contraception right from when she gave birth, instead of delaying for 6 weeks, for 6 months. In most cases, some of these women actually become pregnant before they realize it or before they commence family planning. So it is possible to commence family planning as soon as possible, as soon as a woman delivers. However, there are a lot of issues that come to play in taking decisions as to what a woman needs to be placed on in the immediate postpartum period. There are many conditions that affect this time. One, the woman may be on breastfeeding. The womb of the woman has not returned to normal size. The woman is prone to some conditions, venous thrombosis. The IUCD could be expelled if not properly placed, and issues of other conditions like HIV, hepatitis that may affect the woman. We all know the recommendation for breastfeeding, and if breastfeeding is properly applied, it serves on its own as a means of contraception. But unfortunately, that has not been well utilized in our society. Happily, in 2015, as we're talking about this new WHO recommendation, they've come up with some specific recommendations which, well applied, could serve as a proper means of preventing a woman from becoming pregnant unplanned. And if you look at the next, please. Next. Okay. Next, move on. Move on. Move on. Yes. If you look at this table if you look at this slide, you'll find that there are methods of family planning that have been listed there, and they've been given some values according to the last edition of WHO recommendation. But over time, with the 5th edition of the medical eligibility criteria, these criteria have changed. We all know category 1 and 2 shows that the method is good enough, could be used, while 3 and 4 indicates that, 1, that method should not be used during the period. So if you look at the board there, you'll find that the oral pill is probably not recommended in the immediate postpartum period, that is less than 6 weeks, while the injectables are also not recommended. The implants were not recommended until when the woman gets beyond 6 weeks. Also, if you look at it, the LNG releasing IUCD are also not recommended, especially if the woman is breastfeeding. But researches have now shown that some of these recommendations are not really the way they are. That some of these methods are actually safe if properly used in the immediate postpartum period. If you move on, please. If you go on to the next slides, based on research findings, WHO has now recommended in the latest revision, move on, please. Move on. Yes, if you look at this slide, this is now the WHO 5th edition recommendation, the current recommendation. You'll find that the oral pills, especially the progesterone oral pills, cannot be used without consign in less than the first 6 weeks, within the first 6 weeks of delivery. Only the injectables still have some consign, but the implants can be used within the first 6 weeks of delivery. Again, if you look at the LNG IUCD, you'll find that it is not possible to put an IUD on a woman within the first 48 hours of delivery. Within the first 48 hours of delivery, a woman can be placed on IUCD, and after that, no use of IUCD. Then after 4 weeks, the woman can generally use IUCD, as recommended in the recent review. Then look at the real issue that many people are concerned about is the issue of oral contraception. That is the combined oral contraceptive pills. There are specific recommendations right now, and if you consider the summary here, it is stated that for women who are breastfeeding and less than 6 weeks postpartum should not use combined hormonal contraceptives, that is the combined oral pills, contraceptives, vaginal ring, combined injectable contraceptives, based on the fourth review. But currently, breastfeeding women that are breastfeeding women more than 6 weeks to less than 6 months postpartum, primarily breastfeeding, generally should not use oral pills. That is on category 3 in the last recommendation. But if you look at the current recommendation, it is now stated that women, please move on. Next. Next. Yes. If you look at this table again, it is now made clear by WHO that within the first 21 days, I want to look at what I'm talking about so that we can be saying the same thing. Sorry. Yes, that within the first 21 days, if there are no risk of venous thromboembolysis, that the oral pills, combined pills, injectables, and the implants can be used, and they all fall into category 1. But those women that had a risk of venous thromboembolism, it should be avoided. But after the first 21 days to 6 weeks, it is found that almost all methods can be used, ranging from the combined oral pills, the patches, the ring, the injectables, the implants can be used in all women if there are no risk of venous thromboembolism. And after 42 days, it's also found that you can use every method. There is no restriction. All methods can be used in women immediately that woman has achieved 42 days. Compared to previously where only few of these methods were recognized and accepted for use. Then if you look at the next slide, please. If you look at the other methods, it is found, considering IUD, breastfeeding women and no breastfeeding women with puerperal sepsis should not have IUCD insertion. Because we have now said that it is possible to apply IUCD for women immediately they deliver. The only exception in this category is women that end up with postpartum sepsis. We should avoid IUCD in them. But every other woman can be placed on IUCD within the first 48 hours of delivery. This is just a flow chart to show the various types of family planning methods and how they can be used, ranging from taking all women into consideration, those that are breastfeeding and those that are not breastfeeding. And if you consider the period, and if you consider all these periods, you'll find that ranging from progesterone-only pills can be used across board, no restriction. For women for IUCD, can be used within the first 48 hours and after 4 weeks. Can be used throughout. And for female sterilization, this also can be used within the first 3 weeks and after 6 weeks. Progesterone only pills is acceptable. Condom can be used by all women. Diaphragm can be used. Lactational amenorrhea also can be used by all women. So with this recommendation, it is now possible to place our women on many contraceptive methods that normally they would not have been given in the previous recommendation. So in conclusion, women who breastfeed have more safe contraceptive methods. Implants can be used. Implants can be used. We can also use IUCD. And even women who decide to go for sterilization based on the number of children they had and whatever preference they have, they can be qualified for such methods. And no breastfeeding women can initiate many methods immediately after breastfeeding. Most of these recommendations are, even though we cannot discuss them in detail because of time, you'll find that there's a document that will be supplied very soon. It contains more information about the various methods, how they can be used, when they can be used, and the recommendations based on the WHO guidelines are well spelled out in those documents. Thank you.
Please help me in appreciating Dr. Agbogoroma. You can't fault him in his area of core competence. And he has just reminded me of the struggles I had 20, 30 years ago. with balancing home front with the office. You know what it is for a woman. Thank you very much. Please, let's welcome Professor Adekunle to take us, give us a snapshot of emergency contraception and adolescents with recommendations. Thank you.
Thank you, Dr. Adebimpe. I'll start with the new recommendations for emergency contraception. Yes, thank you. A pity we were not able to present the fifth MEC edition itself, because we'll have mentioned other things like the new things, the new methods that have been added to the fifth edition. You know, most of us are familiar with the fourth edition, but the fifth edition, the 2015 edition, they've added new methods of contraceptives. One of them is an emergency contraception, and that is ulipristal acetate. But I'm going to discuss the new recommendations altogether in 3 minutes, I hope. So we all know why women use emergency contraception. Condom breakage, late for injection, forgot to take the pill, did not abstain from sex during fertile period, sex was unplanned, especially among the adolescents, or unable to negotiate partner, or sexual assault, which is very common these days. Any woman who has unprotected sex and does not want to get pregnant should use emergency contraception. Now, we've been familiar with two types of emergency contraceptives, the pills and the copper-bearing IUDs. The pills, we started with the USP regime, okay? But in the last 2 decades, we have introduced the levonorgestrel ECPs, which came in at first as 0.5 milligrams pill, which you take 12 hours apart within 72 hours. But that has been extended to 120 hours. That is one of the new changes now. 120 hours, not 72 hours. 120 hours. Then copper-bearing IUD. The copper-bearing IUD, we've always known that that can be extended to 5 hours. Now, I quickly move on to the copper-bearing IUD for emergency contraception. Now, one major area where the copper-bearing IUD is very useful is rape. In the fourth edition, it wasn't separated, particularly in rape. It's been separated in the fifth edition now, because you can have rape cases with high risk for STIs. You do not want to use a copper-bearing IUD. But if there is a low risk for STI, then you can use a copper-bearing STD. You see that in this table, the second row, high risk of STI with rape is now put in category 3. And low risk of STI with rape is now in category 1. But IUDs do not protect against STI, HIV. You still have to go ahead and investigate the rape victim. Now, using copper-bearing IUD as EC, they are recommended for post-rape care. Now, there are 2 IUDs now in the 5th edition because they have introduced the levonorgestrel IUD, which we refer to as Mirena. Okay? Most of the ones we see in this country are called levonorgestrel releasing system. But WHO has recognized it as IUD. I know a lot of my colleagues still want to call it NLG IUS. That is, they will not just try intrauterine system. But it's well recognized now as IUD. It is not effective for emergency contraception. Please, do not use NLG IUS or NLG IUD for emergency contraception. It does not work as emergency contraception for rape cases. Where possible, please always use Now, the ulipristal acetate, UPA, is the new emergency contraceptive. It's a selective progesterone receptor modulator. And a single dose of 30 milligrams is effective up to 120 hours, just like the other ECPs. Like, it delays ovulation, that's the mechanism of action. It's been out in Europe since 2009 and in the US since 2010. It's been registered in 72 countries, including countries in Africa. Now, I will skip that. So what are the new ECP recommendations? You can see that most of these are in WHO MEC Category 1 or Category 2. Before, previous ectopic pregnancy was in Category 2. That is, be cautious. You can still use it, but be cautious. But you now see that is in Category 1. We are going to talk about obesity later. Then, history of severe cardiovascular disease, because we are dealing with hormonal ingredients, has been moved to Category 2. Okay? Migraine, Category 2. For all of them across the board. And the CYP3A4 inducers. And Category 1. Now, I'm sorry I'm rushing, but so, now, ECPs and breastfeeding. Oh, please, can you move? ECPs and breastfeeding. Are you there? No, the next one. Yes, ECPs and breastfeeding. Now, if you are on ulipristal acetate, if you are using ulipristal acetate as ECP, please do not breastfeed or tell the patient not to breastfeed for 1 week. Because it will be expressed, it will come out in the milk. So the milk should be expressed and discarded during the time. Do not breastfeed for 1 week, but keep expressing the milk, but don't use it. Now, if you've been looking at the ECP literature on the web for almost 1 year now, there's been a lot of discussion on ECP and obesity. And a lot of articles came out as to who can use it, who cannot use it. And, okay. But let me just summarize this. If we find out that if the BMI is more than 30 kilograms per meter squared, and you're on ECP, it may not work. It may work, but if it's less than 25 kilograms per meter squared, it will work very well. It's just a slight difference. So, let me move on. Then ECPs and CYP3A4 inducers. There are some drugs that are CYP3A4 inducers. You have drugs like rifampicin, phenytoin, phenobab, and including nevirapine. These can affect the effectiveness of ECPs. So when you are using these drugs, please bear that in mind. There are some exercises here, but I'm not sure we can go through them. So it's just to let you know that ECP cannot be taken 5 days after the exposed sexual intercourse. And how emergency contraceptive works. It cannot destroy, it cannot work after the embryo has implanted. It cannot work. It has to be, it only works, it prevents fertilization. So please bear that in mind. Sorry, I can't explain all this. So let me summarize. Okay, so please.
Sir, we want to thank you very much. We really understand. In fact, some of your students have informed me that you are an encyclopedia. Dr. Kayode Afolabi, you just give a snapshot, please, on lessons from utilization of WHO FP guidance documents to update national FP service protocol and training manuals in Nigeria.
I'll be talking from strategic and policy point of view on behalf of the Federal Ministry of Health and all stakeholders that work to ensure that we have this fit edition of medical eligibility criteria by WHO incorporated into our in-country document, including the family planning service protocol and the family planning training manual. We had a good opportunity that we leverage on. There were 2 high-level events that occur around the same time. They are actually global events on postpartum family planning, as well as the International Conference on Family Planning that took place in Bali, January this year. We started our work by looking at a country implementation plan on postpartum family planning. We identified lead agencies like USAID, UNFPA, JPIGO, Pathfinder International. We work with them to identify what we catalyze our implementation plan on postpartum family planning, and we also assign responsibility. And for us to adapt the fit medical eligibility criteria recommendations from WHO, we had 2 meetings, which was a broad-based stakeholders meeting, including all stakeholders in family planning in the country. The first was in Kaduna State in December last year, and the output of that meeting was an initial draft of a review of our current FP service protocol and training manual. And we further refined this by having a second meeting. You can go on with the slides. I will not be working by the slide because of time. We can go on? Okay, thank you. So the second phase, we refine the initial draft further with core stakeholders in family planning, especially program managers and implementing partners. So by this, we had a final draft that captured all the new recommendations of the medical eligibility criteria, which was approved by the Honorable Minister of Health. So our next step now is that we want to actually launch this document. Is presently in print. We'll soon be conducting the launch. Now, what are the lessons we learn? We realize that it's important for us to get sensitized early, and we use the opportunity of those 2 global events to ensure that country delegates get sensitized about the new recommendation. And also, the fact that job aids were made available early enhanced our work. WHO made this available to us at the federal ministry and to the state level, which we circulated to service delivery points. And finally, the fact that we had resources. This was actually made possible because we do a joint work plan with WHO. So resources were available for this review, and we leverage on that. That gets us to be able to finalize the draft and get it approved by the Honorable Minister in good time after the review by WHO. So I thank you very much.
Very much. The whole essence of this session is just to make sure that all the stakeholders are aware that due processes were followed with best practices endorsed by the WHO actually followed in the development of our policy documents. And we have as my co-chair the representative of WHO in this meeting, Dr. Andrew Mbewe. I will want him to take over from here while he introduces the next aspect to us, and we conclude. Thank you.
So thank you very much. We hear that we have very little time, and therefore we will ask Taiwo just to present briefly some of the things that he had planned to present, and then after that we will get some feedback from you, very, very brief. Thank you very much. Taiwo.
To round up, I'll be showing us some of the innovative WHO family planning tools under development. The first one is the Postpartum Family Planning Compendium. This is to help healthcare providers to make decisions about the methods that the woman can use during the postpartum period. So this compendium, this is the website. We can interact with the compendium. Next slide. Next slide. This is the... Okay, we'll go back to that. Okay, for example, we can take this case study of a 32-year-old woman who delivered a healthy baby, 38 weeks, at the local hospital, breastfeeding, has history of hypertension and smokes, interested in contraceptive implants. Is she eligible for the implants prior to her discharge from the hospital? This tool is to help the healthcare providers to make that decision, and the healthcare provider will take information from this case study and plug into the compendium. Next slide. So yesterday, that's within 48 hours. Next slide. Breastfeeding, the healthcare provider will put that on the compendium. Next slide. Then the medical condition, hypertension. Next slide. And then this interface will come out showing the postpartum period and the method that the woman is interested in. Next slide. When the healthcare provider clicks on this, next slide. Next slide. And then this information will pop out about the method that the woman desires and the description, how it works, and some comments about it. So that is all about how to use the compendium. You can go to the last slide. The next one, the last presentation. The next innovative tool is the electronic medical will. This is, right now we have this in the hard copy. Healthcare providers use their hands to spin the wheel. But WHO is developing the electronic one. You can move the wheel to the desired condition to see the methods that the woman can use. If you click on the arrow, the curved arrow, Can you click on the curved arrow? Yeah, that will flip the wheel. The healthcare provider can read more about the conditions and all other instructions in the MEC wheel. So WHO is developing this, and in future, both will be available for healthcare providers on their mobile phone or any other Android device. They can quickly scroll through and then use this to expedite decision making. So thank you very much.
I know we skipped the experience sharing on the dissemination of the 2015 MEC SOGON, and we are sorry, but we are constrained with time, but we hope that Dr. Abogoroma will be able to maybe tell us one or two during the discussion time. Because we have very short time, I know you may have some things to clarify or some things to comment on, and therefore we will only take a few restricted comments and questions. We will be very gender sensitive as well. So we will only take two. Okay. Can I see your hands? Okay. We will start with the gentleman at the back as one. No, you are the one at the back. Yeah. And then number two. Any lady who wants to ask about emergency? Okay. And three. Thank you very much.
Mine is not a question, but it's just an appeal to WHO and the Federal Ministry of Health here. And it's on the distribution of the MEC wheel. Most of us here are product of institutions, and the MEC wheel is for service providers, doctors, nurses, community health care, community health extension workers. And all of us are produced by institutions. And I think it is going to be very important if these things are directed also to institutions where these things are taught. I understand the SOGON has been involved because of the obstetrics and gynecology department that teaches. In the teaching hospital, we also have the community medicine department that teaches, the School of Nursing, the School of Health Technology. They also teach, since we have the tax shifting project. So I think it is very important if the WHO and the Federal Ministry of Health have a collaboration where they ensure that these things get to these people that teaches those people we dish out into the system. Otherwise, we discover that we will come out of the system. We have not even seen the MEC wheel before. And when we come here, that's the first time you'll be seeing it. So people who attend this kind of program tend to have access to it. But people who are taught in school will never see it until they have the opportunity to come here or to be trained in certain programs. Thank you.
M.M. Musa. My question is directed to the Prof. I understand you mentioned two types of the AC, which you discussed of the ACP and the IUD. So my question here is, do we have any health implication if one is taking the contraceptives? And also, the second question is, you said after 5 days of the district. So does that mean if a woman takes it after 5 days, it has another implication?
Thank you very much.
The first one, ECP does not have any effect on the woman. Even if she gets pregnant and the pregnancy continues, it doesn't have any effect on the baby. Remember, the amount of drug we are using is so small. It's so small. So one thing I couldn't get to, before we used to say that once you take an ECP during the month, you cannot repeat it again. But the new guideline says you can repeat it even in the same month. Then the IUD, again, is very effective. It doesn't have any effect. It doesn't have, in fact, in some cases, the woman may even want you to leave the IUD in and don't remove it. So a woman who has been using ECP maybe for some years will just continue to be an IUD user. So it doesn't have any effect at all. Let me stop there.
Distinguished ladies and gentlemen, I just want to thank you very much for your understanding, and cooperation. I believe the panelists are still very much around, and you can still interact with them as much as you will want to. Thank you very much, and God bless you.